Good afternoon, our dear viewers. Welcome to our 117th session, eco session, since we started. And this is our 10th since this year started. And it's also our third session about Ebola since we had the outbreak. We are so excited to have this session. In house, we have experts. Our panelists are experts about Ebola. And we can't wait to have this session. So I just call on you, our dear viewers, please share the link to your fellow colleagues, call them and remind them that the eco session has started. And our time, we don't have too much time, it takes only 2 hours and we'll be out of here. So we are excited and welcome everybody. In house today, we have a team of experts from Emergency Medical Services, and we are going to be introduce ourselves. I, the moderator, am Kwagala Rachel Semogelele. I'm an emergency resident, third-year emergency resident. I'm very glad to be here because I'm expect to learn a lot from my panelists. On my right, I'm going to welcome the expert on my right to introduce yourself to the viewers.
Thank you so much, Dr. Rachel Kwagala. I am called Mohanji Joel Oteho Ahabwe, medical officer working with Emergency Medical Services. I support with the regional EMS coordination for the Greater Kampala metropolitan area. And happy to be here and ready to learn. Thank you.
Okay, thank you so much, Dr. Joel. We are glad to have you today. Welcome the expert on my left to introduce yourself to the viewers.
Thank you so much, moderator, and good afternoon, all who have joined in. Thank you for joining in. My name is Okiror Andrew, and I'll be part of the people on the panel today. Thank you so much.
Hey, you're welcome, Andrew. And we have one of our experts who is online, and that is other than Dr. Marion Nacheyune. Dr. Marion, you can please introduce yourself to the viewers. Dr. Marion, if you can hear us, please, you can unmute and say something to our viewers. Dr. Marion is trying to sort out, internet issues. She will introduce herself when she's able. We are going to go straight time of registering. I want to encourage our dear viewers, please go into the chat and log in, register, tell us your names and where you're viewing from. Also, please don't forget to share that link to your fellow colleagues and to call them. Yes. Dr. Marion, are you in position now? Dr. Marion, are you in position now? Okay.
I'm in a noisy place.
Okay. Yeah, Dr. Marion is still in a position where she cannot unmute, but she's online and she's really catching this session live and she's ready to attend to any concern, any question that might be raised from the viewers. So, our dear viewers, at this time, we're going to go into our expectations. We want to have some feedback to the people who are already now on the chat to tell us what do you want to hear from this session? What do you expect from the experts? What are some of the things you don't want the team to miss out? And I will take some few people. You can put your hand and we'll be picking you up to tell us some of the things that you want us not to miss in this session. Yeah. And I cannot take all of you, others you can write in the chat, but you can have some 1 or 2, 3, 4 people telling us their expectations. Yeah, I can see many people. Oh, we have all our people from South Africa. Hey, Kimberly. I can see Kimberly from South Africa. I can see some from Telego. I can see people from Busia. Yes, we have Katie, Katie from Vermont. Katie, you're welcome. We are excited. We are happy. Katie, can you say something? Can you tell us some of your expectations if you're able? Katie, are you in position to unmute and tell us some of your expectation for this session?
Hi, can you hear me?
Yes, we can hear you.
Well, I just wanted to say, I am very interested to hear more about how patients are transported, some of the protocols that you all are using. I think you're doing an incredible job following here from the USA. It's really incredibly impressive what you all are doing. So I really appreciate the invitation to join today to learn and listen, and just excited to hear more about what you all are doing.
Okay. We are excited. And trust me, we have a team of people that have done this and over. They've responded to every time we've had the Ebola outbreak. And they have much in our stock. They will not miss anything about what you'll say. But thank you so much, team from USA, for joining onto this call. We are really grateful and excited. And colleagues, please don't just keep on that link. Share it to your fellow colleagues so that they can get this information, they can get this knowledge. As my teacher keep on saying, patients don't come with labels, with disease labels to tell you that me, I have malaria, me, I have Ebola. They don't. But you just know, you work on the patient, and before it, they tell you, I think this patient has Ebola. So this is the information or the knowledge that each and every health worker should have. Whether you work at the ED, whether you work in inpatient, whether you work in outpatient, whether you work in radiology, whether you work in ICU, everybody should have this information. So please share the link. I can see someone's hand is up. Someone's hand was up. Beatrice. Beatrice, please, can you go ahead to unmute and share your expectations?
Thank you very much. Good afternoon, everyone.
Good afternoon, Beatrice.
I'm so excited because of this topic. I was waiting for it when you told us it will be this Friday. I was expecting a lot and expecting a lot still, because this is the era of EVD. We need all this information. Thank you very much.
Thank you so much, Beatrice. Thank you so much. And I assure you, your expectation will not be cut short. Your expectation will be fully filled, answered. Can we have one more person? Can we have one more person? I can see Dandu Joseph from Alua City. People from Alua. Dandu, are you there? Can you unmute and share something? Are you in position? Okay, I think Dandu is not able to share. Let me see. I can see Kasim from West Nile. Adiga Kasim from West Nile. Okay, can see someone's hand is up. Please, you can go ahead to unmute and then share. Can you go ahead to unmute and share?
They can't.
Okay. Okay. So our dear viewers, thank you for the people that have shared their expectations. And thank you to all of you who are sharing the expectation in the chat. I can see in the chat. So our dear viewers, right now we are going to go to deep dive into this session. We are going to have our first presentation from Okirol to give us a case scenario of the real case that has happened in this outbreak that they responded to, and it involved them moving a patient from one hospital to the EVD unit. So Okirol is going to be telling us how did they manage, which challenges did they came across, and how did they overcome the obstacles, all the challenges. So please pay attention and then let's learn. Claude, you're welcome.
Thank you so much, Dr. Rachel, and thank you again, members who have joined in online. My name is Okiror Andrew, and I'm supporting the Ebola response in EMS. Yes, so like the moderator has just told us, this was a typical case that we evacuated, and this was after the outbreak was declared. This was the very, very first positive case that we evacuated from one facility to the Mulago isolation unit. And after case one was a deceased, but this was the one that was picked up by surveillance. So this was a female adult with a Congolese citizenship who was unwell while in Congo, but then opted to travel to Uganda to seek better health care. And this patient was in Uganda, arrived in Uganda on 16th of May, 2026. On arrival, this patient had presented with a complaint of severe malaria, and this is what was being managed from Congo, where the patient was. And the symptoms were not clearing, so the patient preferred to move to Uganda to seek better care. And of course, while the patient was being managed for malaria, severe malaria, the patient had started deteriorating. And the patient from that facility developed difficulty in breathing. The patient was sick, though alert, but had also started developing, the patient had got AKI. And this patient was no longer able to move at that time. When the patient arrived at the facility, the patient could not move very well. So the patient was taken to an intensive care unit where the patient could probably be well managed for severe malaria. However, during the process of management, the patient started developing now clinical, very clear symptoms that are similar to those of Ebola. The patient started getting wet, developing diarrhea. And when this was matched with the Ebola case definition, which had an aspect of travel history as one of the key signs to pick out in the case definition, this patient had traveled from an area where there was already an outbreak in Bunia, Congo. So when the patient started developing the Ebola symptoms, the samples were taken, and on return, this patient was tested positive for Bundibugyo Ebola virus, and this was our case 2 of Ebola that we evacuated. And of course, however, when this patient was evacuated, the EMS team, on arrival at the scene, after they were dispatched, assessed the patient also and confirmed that from what the dispatch had sent them, that this was a patient that was surely positive, tested the laboratory confirmation results, but also the patient was stable. The patient was stabilized from the facility that was managing the patient. The patient was clearly well stabilized and the vital signs were stable at that point. The patient was on fluids and on oxygen therapy. The patient was oxygen dependent because he had developed difficulty breathing. And of course, the patient was non-ambulatory, so this was the kind of patient that EMS had to move from this facility that was managing Mulago isolation unit. A critical patient, positive case with weak symptoms, non-ambulatory, and on oxygen therapy. Thank you.
Yeah, thank you so much, Okro, for that case. And it's typical of what I can look at. Yes, we know we took some time. Uganda took some time. Yes, our neighbors, that is DRC Congo, they were having Ebola, and we all knew as Ugandan that we have Ebola at the neighborhood, but we had never gotten a case. And this is what happened. Yes, you might be working in, let me see, in maybe Jinja, you are in Soroti, you are in the farthest part of the country, and you only had Ebola case in Kampala, in West Nile, and Port Portal region, because so far those are our high risk districts so far. And you're like, when will it reach my area? Doesn't concern me. Maybe I'll not get. And blah, you get this patient presents with the symptoms, because we all know that the symptoms of Ebola virus don't differ so much from other febrile illnesses. Fever, general weakness, pain at the start before the other bad symptoms. So really, let's pay attention to this. I cannot imagine how the people in this hospital, patient comes in as, yes, he's having febrile illness, he's getting worsening, he's having malaria, and we know that malaria causes complications that can require ICU admission, AKI, respiratory distress. Yeah, malaria can affect all symptoms, and before you know it, the patient is confirmed as Ebola virus disease. One, it puts a risk to the healthcare work and also the patients themselves. So, Okro, I know you responded physically to this case. You are the people that transported this person. Can you paint to us a picture of how were the staffs in that facility after them getting the news? By the time we went to find this patient, how were the IPC precautions already put in place, or the facility was trying to restructuring and reorganizing itself? Thank you.
Thank you so much, Dr. Rachel, for that. Yes, because this was a typical case that was evacuated. And again, I would, how they were prepared, it would be hard for me to give the details, because during the evacuation, the EMS team had little time to spend at the scene. Mm-hmm. The purpose was just to go and pick the patient and evacuate the patient and take to the receiving facility. However, I would just say this from the appearance, and of course how the health workers were, and I want all of us to imagine the similar. Just put yourself in the shoes of these health workers. This is how they were, which is of course a normal reaction from any health worker. Just imagine a patient walks in, and this is a patient who was coming for severe malaria. We're managing severe malaria really, and we're trying our best, like I shared. And the patient has been stabilized, and the patient is being managed very well. Then later on, the symptoms start presenting of Ebola, and then the samples are taken. Then before you realize the results come out and they say this is a positive case. How would you react? Of course, everyone was scared, you would have the doubt, get nervous, and all these things would come in. But by and large, at least from what we found on ground, the facility had isolated the patient even before the results had returned. The facility at least had isolated the patient. And of course, they had the PPE on, yes, where the patient was being managed from. Staff had fully done, and they had really taken care of the IPC precautions, including the donning of the PPE from at the point where we were. So basically, that's what I would say. And I would also encourage that I think whenever we're managing all the patients, it's important for us to maintain the IPC standards for all the infections we are managing, not only Ebola, but all any other. Thank you.
Yeah, I'm sorry for bombarding you with many questions. Yeah, our dear viewers, you can see there is a pretest that has been shared. Some questions. Please take some few seconds and fill the pretest that guides us to assess the knowledge baseline of our viewers and to make sure that nothing is missed out. And then we shall have a post-test at the end of it all. Yeah, as we continue with Okrol. Now, Okrol, allow me to ask one more other question. I know this was your first patient to respond, evacuation you had since this outbreak. I know you had responded to many of them in Mubende and other outbreaks we had. But now this one, Ebola Bundibujo, with the virulence and the high mortality letters we know, how did it feel with you? What challenges did you face? If you can summarize a little bit. I know you're going to come in later to talk about many things, but can you tell us what came to your mind? How did you prepare yourself? How did you deal with the psychological stress? And did you face any challenges? Did you go alone with a driver or you had some other person you went with? How did you manage that in hundreds of health workers that we have? I know a few of them will accept to say, let me go and pick out this patient. I know it's a sacrifice and it takes a strong and brave heart to do that. So tell us, what gave you the morale, or how did you get the courage? What challenges and how did you overcome them to compose yourself and respond to this case? Thank you.
Okay, thank you so much. I would speak to that in this way. The Ministry of Health and specifically the EMS department, the EMS, which is one of the sub-pillars under case management, that handles the evacuation of patients and safe referral of patients from facility A to B whenever we have these outbreaks. Now, what I would say is that whenever there is any outbreak, of course, EMS has to respond. So it means within the time of the call, EMS has to respond. Now, how does EMS do this? Usually, there are deployment considerations that EMS puts in place before people are dispatched or sent to go and respond. One of which is, of course, our prior experiences, like you noted, that we've been responding before. Of course, they cannot send anyone who has never had an experience, who has never responded before. Or, for example, when you have students who have come in for internship and they're on duty and they are, because the call is coming and they are being sent to go and respond, no. The deployment considerations are there usually prior experience of response, including training, prior training, or previous trainings. Of course, they brief you. You should also be much conversant with the response protocols, i.e. IPC, things and donning, doffing, and so on, like I will later on discuss during the sessions. But basically that is that before you respond, of course, there are diplomatic considerations that the person who is going to respond is also comfortable with the response and be able to respond.
Okay.
Thank you.
Okay, thank you so much, Okro, for the presentation and the response to those questions. And thank you so much for giving clarity. I think our poll is done. Right now, dear viewers, we are going to go straight into our next item on the agenda, and that's other than for us to have a clear understanding of how the activation of an alert? How is the call? Like if you get a patient, you're working at a health center, you're working in a private facility, maybe you're working in your clinic, and you get a patient that you think could be having Ebola or has a link. How are you going? Who do you call? How do you start to call? Which numbers do you call? How do you appropriately activate and escalate that Ebola alert? How do you handle that call? For the people who are working in ambulance, the other ambulance teams, some of the people who are serving in EMS in the regions, we know we have the 16 regions. You might be in one of the regions. How do you organize that ambulance? How do you coordinate with your regional coordinator? Which protocols are you supposed to follow? Which things must be in place? So we are going to look at how you're handling the ambulance dispatch procedures, IPC procedures before and during transfer of an Ebola suspected case. So I'm going to welcome Joel to come and take us through that session. Joel, you're welcome.
Thank you so much, moderator and the presenter before. Yes, so like you've ably said, we're going to discuss the appropriate activation and escalation of Ebola alerts. How do we get them at EMS? How do we handle our calls, and what do we consider to keep ourselves safe? Because safety comes first, especially for us. You have to be safe first to be able to respond. So yeah, let's dive right in. We want to talk about, yes, activation and escalation of alerts. We want to talk about handling the call and dispatch, and also applying IPC from the start to the end. You know, EMS reaches communities, so there's big risk to EMS responders, to the EMTs on the ambulance, to the drivers, and even the hygienists. So how do we apply IPC throughout our activities? For the next slide, we want to give a background of how EMS operates. There is something called the Emergency Care System Framework. This just really gives the entire scope of emergency medical services. It handles pre-hospital and hospital emergency care for patients. So usually, like I had said earlier, we can reach the community. So the scene, where the alert begins is at the scene. The patient can be in a community, they can be in a facility like the case we had. And that is the part that we have to reach to, the ambulance team has to reach to. Then there is care in between there, during the transportation. There is care en route to the definitive destination. So en route, then the receiving facility, definitive care. It could be a treatment unit, like in our case here, isolation unit. It could be a routine case that is going to maybe a heart institute or a cancer institute or the like. So generally, we reach the patients, provide safe movement of the patients with care in transit, and then take them to definitive care. Yes, so that is the emergency care system framework. So for the gist of this, we're talking about the appropriate activation and escalation of Ebola alerts from a community signal to a verified EMS evacuation, and knowing when to move a patient up or down a level of care. So EMS, in outbreaks like we have now, we have what is called an incident management team. EMS does not work alone. It's part of a structure, and there is an incident management team led by an incident commander that are managing, are leading the response strategically. Then we have different pillars that serve this team, and pillars can be like surveillance, laboratory. We have what we call the case management pillar, which deals with the managing of the cases. Yeah, things like clinical care, emergency medical services, mental health and psychosocial support, nutrition, all are involved in the case management pillar that supports the incident management team during an outbreak. And the EMS sub-pillar falls under the case management pillar. The EMS sub-pillar supports in the management of cases during outbreaks because the cases get to the treatment units through emergency medical services. And also high-risk contacts would get to quarantine sites, for example, through the emergency medical services. And emergency medical services has to be activated with other pillars in the incident management team working together with it. So you can have surveillance where alert management falls. Alert management falls in the surveillance pillar. So where the alerts are verified from, and then with that happening, EMS is activated to provide safe transportation of these cases from wherever they are to the definitive care. So EMS is activated only for live validated cases. Alerts that have been verified by surveillance as meeting the case definition, like Pirot had shared earlier. So case definitions and all that are spread throughout. The different teams in the incident management team know what they are and work together to make sure that the alerts that are going to be evacuated meet the case definition and are true alerts and need to go to either isolation treatment unit or the designated facility. So VHF ambulances that are working to transport Ebola evacuations, you want to have them separate from the ones you're having supporting the routine cases. And you also want to have one toll-free alert line. I'm going to share some of these are going to be shared because we have surveillance team that is handling. We have the Ministry of Health alert line where people are calling, but we also have the EMS line that is also toll-free. And I think in one of our previous sessions, the Commissioner of Emergency Medical Services had shared that we have 912 that is still in development, but we are currently receiving calls on it. And some of the alerts actually we have received for this outbreak have come through 912 and have been managed. So yeah, this gives us a brief on the governance and where EMS lies. So in the alert management system, like I said, we have the surveillance arm where the alert has to be verified to meet the case definition, and then EMS is evacuated if these alerts are verified as correct alerts and true alerts. So the alert call desk will receive a call from the community or a facility, and then it has tools it will use, maybe alert verification form, alert logs, to check if the signs and symptoms, the travel history, for example, the case we had, then this verification is done. So by the call receiver who receives this call, and with the tools, and then they check with the case definition if this case does meet the case definition. Some are false alerts and are discarded, but several of them end up meeting the case definition, and they require field verification. So the surveillance team, which manages alerts, has field officers that can reach the various places where these alerts are coming from to actually confirm physically that these alerts meet the case definition and have the signs and symptoms that are reported. Yes, and sometimes it's really quite clear, and EMS is quickly activated. So the alerts have the signs and symptoms and probably have the travel history, contact of probable confirmed case. So you find that EMS has to be activated immediately to go and evacuate this case to the isolation treatment unit, like we can see in the diagram. Then the cases that are dead or for death alerts, we have another sub-pillar that deals with those, which is called the safe and dignified burial sub-pillar, also under case management. So we do not expect ambulances to transfer to transfer dead bodies. They are only for live cases that have met the case definition. Yes, so the safe and dignified burial will handle the dead cases or the cases that need to be handled by the teams trained to handle with dignity and safely deceased patients. Yes. So yeah, that is briefly what the alert management system and how EMS comes into play with the alerts that we receive from the community and facilities. So this is just to really take us through what we have discussed. The bystander will call the alert desk, and then the alert will be verified if it's genuine or not against the case definition and other tools, and then a decision will be made either to verify in the field physically or to send the EMS, activate the EMS pillar or activate the safe and dignified burial, depending on what the case is. Then when EMS is activated, it will reach the cases and will transfer them to the definitive point of care, which is the isolation or treatment unit for Ebola cases or suspects. Okay. Yes, so this still just talks about what we have said. And we really want to work within the structure. We do not want to have EMS going for unverified alerts. And in some instances, we have had cases where we have reached the alerts and they do not meet the case definition. Yes, which we have had to discard as EMS because we reach the field or wherever the community or wherever the case is coming from, and probably something was missed in the verification, or there was no confirmation, or there was exaggeration, and you find that you have to discard the alert when the EMS team has already reached the scene. And actually, some have actually even been transported, but then together with the case management team as a whole, you discover that it is not meeting the case definition, and then you reroute to the proper point of care, if it's a trauma case or if it's a medical emergency that doesn't meet Ebola suspicion. Yes. So we have tools that are used in verification and surveillance pillar, or the alert management teams and the field verification teams. We have tools that they use, like the case investigation form. We have what we call the CIF or case investigation form that really ticks the boxes and matches these cases or suspects or alerts to the case definition. So of course it picks the demographics, and then it picks other details like travel history, and then it picks the signs and symptoms. So we always, as EMS, when we're activated, they present to us a CIF as proof that this case has been verified and meets the case definition and is due or requires evacuation. So the alert management team has, of course, its system. It has its alert log. It has its surveillance systems and algorithm that it follows, and of course desk officers and also field agents. Then when the CIF is filled, it is proof enough to the EMS team that this case, and of course contact details are also there, so we can communicate with the teams and then have that information that we need as EMS to respond and also report to the receiving facility. Yes, so the moment surveillance marks a case as validated, we have many things that go on. Because when the EMS desk receives this case and they realize it is a verified and validated case that requires evacuation, many things have to happen at the same time. There has to be a team ready to go. There has to be a treatment unit where they're going to take this patient, and the treatment unit has to be ready. There has to be triage done by EMS to know what particular team requires to go and what particular needs the team requires to move with. Also, the EMS has to keep track, has to keep record with this dispatch they are going to make. So an ambulance team is made ready. Treatment unit is also alerted to prepare a bed and a team to receive. Triage is done by the dispatch officer of the EMS to know, is this patient a wet case? Is this a dry case? Do I need, because we differentiate the ambulances like we're going to see, and then dispatch the proper team, knowing where they're going to and where they are taking after they have received this patient. Okay, so some things happen during the transfers, during the evacuations, and that need escalation. That you can have a worsening patient en route, and you need to alert the dispatch. You need to have support. You can have because, like Okirod had shared, there is training needed, retraining needed, and there is a need for teams that have experience, that have done this before, because of the level of risk involved. Because in the previous outbreaks, we have had instances where we are getting exposed. So because an ambulance is really a small room to work with. If you're in the patient cabin, it's a small room to work with. And if you are in there with a confirmed case, then you want to make no errors. You want to make no mistakes, because this room is small. There's high risk. You're in contact, and these diseases we know are spread through contact. So you must have the utmost level of care and the utmost level of protection with you. So you must be really comfortable. That means you must be trained as much as possible, and you must have enough experience. So when you have a worsening patient, for example, you will need support from even teams that are more experienced. And when you have an unstable patient, you have to stabilize that patient before, because like we have said, the room is little. So it's better you stabilize from a facility, for example, where you have much room, and then by the time you move, I have maybe an hour or 30 minutes to reach the destination. I can manage to reach when I am still okay. Then challenges with the mechanics, conditions of the vehicle, with the treatment unit, all those things must be escalated. So you must communicate. Constant communication has to happen, and you must make sure that those things, even that's why you prepare. You want to have a smooth transfer. So preparation is very key. But in cases where you find issues during the transfer, you must escalate to the right level. Then also, when you are done with the cases, you also have to report back when you have decontaminated the ambulance, documented. You must report back to the call center, the EMS call center, such that they know now we have more resources available in case we have another case for transfer. Yes, so some pitfalls that can go wrong during this process. You must ensure that you verify these things, because you do not want to make errors. And we talked about the risk. So when the responders are receiving the call communication from the dispatcher, they must communicate back, read back to make sure that they're getting the right information. Sometimes we share names. You can mention male instead of female. It can be a mistake, so you have to read back, and and someone has to verify. The caller has to tell you, yeah, I think you've got it right. Then, so all these things, the alert verification, CIF, even the people going to respond must see it, must know that this case has been verified, and I'm sure I'm going to the right place. They must also report that they are going for this, because data is key. You must document everything you do. And then, so we want to move only for the validated cases. So let's ensure whenever we are going to move, we have all the details right, and we are going to the right place with the information reconfirmed or second. Yeah, you proofread what's the information you get. So for the second part, how do we take the calls? How do we triage and send the right team? Because different patients have different needs, different triage categories have different needs. So the call taker really receives, so when EMS is activated, the call taker will receive this information from the surveillance team, sometimes directly from the community. They get the demographics, they get the condition, and then call taker and dispatcher are in the same place. Sometimes it could be the same person at the EMS call center. So the dispatcher does the phone triage and gets the location, asks about the condition basically. Are they a wet patient? Are they a dry patient? How long have they been sick? That information that really gives you an understanding of how sick, how ill, what you could need to move with, what you could need to move with. Are they vomiting? Are they diureting? Is there diarrhea? And that we have a pre-hospital triage tool for VHF, which will categorize our patients as priority 1, priority 2, or priority 3, depending on the symptoms, if they are wet or dry, very ill, and then priority 3 are the green patients who are able, sometimes are ambulatory, able to move. They're not very sick and are able to follow instructions and maybe ambulate. So with that information clear with the EMS team, they will now assign a team and ambulance depending on that triage priority, and then we'll also notify the treatment unit. So they will give the treatment unit notification of this case. We have a case we're going to bring to you. The patient is very ill, they're wet, prepared to receive. And they will also give the expected time of arrival, maybe in an hour, 30 minutes. They are coming all the way from, Michiana, outside the metropolitan. And the ETU will now prepare in advance. They know now I will need to prepare maybe fluids. I need to prepare things that will support in the patient who is vomiting with diarrhea, antiemetics, all those things. So the ETU will have information on how to prepare, but also the team going to pick, the evacuate will also know the condition. Then the dispatch will be made, and the information will also be logged in the EMS dispatch system. So all this should be done. It's done quickly, really, because even the response time is one of the things the EMS wants to improve and is always working on to improve. And everything is captured in the alert management form as well as the EMS dispatch system on board. Yes. Yes. So what the call taker and dispatcher capture, we have already mentioned. Everything: the demographics, location, clinical condition, the source of the alert, the caller, what number can they call back, the alert, the team that is going. They do the phone triage and obtain clear directions and capture all that information in their system. Yes. And then, like I talked about the pre-hospital triage tool, we have priority 1, priority 2, and priority 3 patients. And priority 1 are the red patients. They are the sick patients, very sick. They need continuous observation and monitoring, and they are wet, bleeding, maybe diarrhea, vomiting. And the priority 2, they have symptoms as well, are very sick, but not to the level of priority 1. Yes, so they could have maybe non-bloody diarrhea, less severity. And then the priority 3 are the green patients, dry symptoms. The patient is walking, talking, and then, of course, we want to reach, EMS wants to provide safe transport of the cases to definitive care from wherever they are. So you must make sure the patient is stabilized if they're very sick for transport, but also you want to get the sickest patients first to where the treatment unit is, where they can receive the utmost comprehensive appropriate care. So triage really drives everything downstream, how urgently we move, which team goes, which ambulance, and how much decontamination is needed. Because if the triage, the dispatcher finds out this patient has very sick, very wet symptoms, they are having a lot of episodes of diarrhea and vomiting, then they will tell that team that is going to evacuate to move with more material that can support that, like biohazard bags, and also, to the appropriate PPE that they need. And also the decontamination will be more thorough because we shall have more viral particles that are contaminating the ambulance if this patient has been shedding off all these particles with their wet symptoms. Okay. Yes, so we do emphasize triage because of how important it is in our decisions we make. Yes, so it's very important that we move a patient when we are sure where they are going. So you must make sure that the treatment unit is in the know and is ready. You have to confirm bed space. You have to confirm if there's ability to manage, for example, a patient with oxygen needs. Sometimes the technology is down, the instruments are down, and that's why we emphasize the communication beforehand. When the treatment unit is aware, then they can say, okay, we can improve, we have maybe oxygen for this, or we're not yet ready. Let's hold a bit. So all those decisions come when communication has been made. And then we have ambulances that we specify for the very wet patients and ambulances that are designated to handle the dry patients, less risk, and then the ambulances that are kept for the routine cases and other emergencies. So we do not mix those, and we keep that distinction clear. So when you have that trial information, you can now know this is the ambulance that will go, and this is the team that will go. Okay. So yes, so like I shared before, you confirm bed capacity, you give the treatment unit the expected time of arrival, you share the clinical picture such that they prepare adequately, and then the receiving team also gets ready. When you have a patient from a nearby facility to the treatment unit, then they know we have only 20 minutes to prepare, so that the team going to receive you can start donning in 15 minutes. And yeah, by that time the ambulance will be here at the receiving bay. And then yeah, all that is captured. Then sometimes a evacuation has to be delayed, and there are some reasons that can lead to that. For example, we talked about an unstable patient. An unstable patient will need to be resuscitated first for that transport. They need to be made. How long is the transport? Where to? And are they fit for the transportation? Then if you need more experienced people or specialized EMT team also, that can be arranged. So we can have a delay in transfer back when we want to get the right team to handle the right patient. Then also, depending on which part of the country or which part, what the scenarios around, you have to assess the risk. So it's different for every case. Sometimes in a very remote place, a rural place, and it's dangerous to have night referrals in such places. No electricity. You'll not be able to do your IPC clear. You'll not be able to don well or to see all the things that you need to see to prevent infection or spread of infection. So that risk is per case basis, and depending on the area and the resources and the environment, really. So the environment really matters a lot. For example, in the 2022 outbreak of Mubende Kasanda, it was deep in the community, the rural community, and it was risky to have night transfers. But in Kampala, between facilities, you can clearly have good visibility. You have resources that can enable transfers to happen even after 7 p.m. And refusals or aggressive cases, there are some cases that we reach the community and the community itself is resistant. They have other beliefs. They have they do not want to comply. We have protocols for deploying evacuations. You have to because we are working with the communities together. So you have to involve, of course, the community leaders, and so we have the village health teams, these teams that communities know. We have the local council leaders. They can really help when emotions are high, when people are not believing what you, the responders, have come to do. So it's important that we involve we use the structures in the localities we go to, and then we have the mental health and psychosocial support teams. Those ones are also part of the case management pillar in the incident management team. Those are really our colleagues that support not only us as the responders, because we also go through the mental stress of the response and we need psychosocial support, but they also have mechanism and tactics of how to engage the communities and the aggressive people, and then support us to de-escalate that resistance. Yeah, but you can reach as far as step 3, where you have to escalate to the leadership, which is the incident commander or the deputy incident commander. Mm-hmm. And they when you escalate, of course, now it's beyond you. Then solutions will be good at that level. We can go to the next. Yes. So you must make sure that you have some things right. Sometimes you have suspects who are children and you don't want to transfer them alone. You need a caregiver to accompany the child. You must have the case specification form before evacuation as EMS. You must also secure things like IV lines, things like oxygen if this patient does need them, vomit bowl or a bag or a pamper for wet patients. Those are some of the kits that the EMS team has with them, prepared to help with them for evacuations. Then also you must know how to escalate, and and those things are key for every evacuation, really. Yes, so these are already mentioned. Now for the IPC, and IPC is really a cornerstone for a response, and it can make or break with all the areas in the response, because any mistake there, we are not safe, and if we're not safe, then the community is not safe, the patients are not safe, and that means that is doomed. So we must protect ourselves, then protect the patient, then the community is protected at every step. And with proper IPC precautions, most times you have 0 responder infections. With just the simple IPC precautions that seem ordinary or usual, trust me, a lot of infection spread has been prevented. Washing our hands, gloves where we need to use them, masks. Those things have really protected us, and we need to have the proper precautions at all times. So before, during, and after transfer, like we're going to see, we need to have the IPC precautions done right. Yes, so for an ambulance, for this anatomy, we have for such outbreaks, very infectious diseases, we want to have separate cabins, like our Land Cruiser ambulances, have a driver cabin. Even some of the drone ambulances, the driver cabin has a separation from the patient cabin. That means the driver cabin is going to be kept as a green zone. And then the patient cabin, of course, will be carrying our suspect or confirmed case. That means it is the high risk or red zone. So the ambulance driver really maintains their cabin. They do not need to don fully. So the level 1 PPE, minimal PPE, they are keeping the cabin is separated physically from the patient compartment. So they stay in that green zone. And if the EMT, that is the emergency medical technician that is going to handle the patient, has to go with the patient at the back, depending on the patient needs, they have to really don fully. If they are going to be in the patient cabin, they have to wear level 4 PPE. So that is donning fully, and then they can provide care en route, depending on the triage category of this patient. But we try to have as minimal contact as possible. So if you have a priority 3 patient, a green patient, you do not need to go in the patient cabin with them. They are talking to you, they are ambulatory, you guide them, you open their cabin, you lead them in, you guide them in, and you go back to the driver cabin with the driver, where you will, of course, remain in minimal PPE, but the patient will be in the patient cabin, and they're still able to communicate to you because you're in the same vehicle, and you can move them to the ETU in that way. But for every transfer, we have the hygienist team, a minimum of 2 people who are going to decontaminate the ambulance at the designated site for that. And we try to make sure the ambulances have as minimal equipment. We don't overload the ambulances that are handling highly infectious diseases, because it becomes harder to disinfect with several pockets and crevices and compartments. Viral particles can hide in there, and you take longer time to decontaminate and make the ambulance ready for another dispatch. So we strip them and leave them as minimal as possible, and then try to handle case by case depending on the triage category. So yes, have the right PPE for the driver, level 1 for the EMT going to be in the cabin, level 4, then usually there are 2, because the case, you can't do all those things. You need a buddy to check on you. So the 2 EMTs that are going to handle the case in the patient cabin do check on each other. They're each other's keeper. Make sure your colleague is donned right, and you're also donned right with their confirmation, and then you can provide care during transit. So we have a simple ambulance with minimal equipment that can easily be disinfected. Then we have confirmed bed space and CIF, the case notification form, and then we also have our care package that we need to move with depending on the triage category. If we need to move with a vomit bag, if we need to move with more, disposable bags, then we can do that. And yes, so you keep the green zone clean, the green driver cabin clean, and then you can use the patient cabin if you need to provide care. Yes, so any waste that is generated in case you're providing care in the patient cabin must be handled very carefully all EMS waste is clinical waste. The sharps, the PPE, the vomit bags that you went with, and all those things are disposed at the designated point. It preferably at the treatment unit where you're going to have the decontamination done as well. So dispose at the treatment facility, wrap your tools. If you have documents that are physical, now we have gone more digital, but if you have physical documents that are being shared between the healthcare workers, then they should remain in the green cabin in a clear bag, and then they can be shared to the treatment unit also in the green zone, not in the patient cabin. Then documentation is very key. So at all times, let's report timely, daily, and we are in a digital era, so we digitize where possible. So the entire transfer, we are maintaining IPC preparation. We have the IPC supplies. Then before we are confirming the EMTs, the drivers, if you're going to have physical documents, you want them in the driver cabin in the clear bag. Then during the transfer, depending on the kind of patient we have, we can keep minimal touch, no touch. Or if they need care, we can have a team of 2 EMTs done and provide care in the patient cabin, and also handle if the patient is very wet. Then after patient has been received, still minimal touch handover. They doff at the treatment unit as designated, and also decontaminate the ambulance, and then report with the decon complete and restock for the next dispatch. Yes, so winding up. Yeah, this is really just to summarize what we have talked about. We want to move for verified live cases. We want to move for cases that have been come through our surveillance pillar with the case definition that is made. We want to have our team triage the case such that the ambulance that goes is appropriate, the team that goes is appropriate, and the ETU is confirmed, is communicated to the treatment unit that is going to receive. So you confirm a bed there and also give them your expected time of arrival, your ETA. So the driver must be in the green zone, and then the EMTs that are in full PPE can support patient care en route in the patient cabin, but also for cases that do not need touch, we really mean strictly be non-touch, minimal contact, you guide them to the cabin. Stabilize cases that are not fit for movement before you transfer them and you escalate. Then for the very young ones, please travel with a caregiver. And for cases that are going to be transferred at night, assess risk depending on the environment. Decontaminate after every single transfer. Let's remember to document, so log it, protect it, and report it immediately, then escalate problems as soon as they come or as soon as anticipated. Thank you so much.
Wow. Thank you so much, Dr. Joel. It has been long, but thank you so much for taking us into that deep dive into how the codes are activated, alert. How do you ensure that IPCs fold in during the transfer? How do you care for this patient in the ambulance? Thank you so much. And I don't know whether people that our viewers do have the same questions that I have. Very many things have been going through my mind while he was sharing. You talked about as imagining someone who has a referral document. So when you talked about the referral document should stay in the patient in the driver's cabin. At first, I thought that you're going to sanitize them after hand over the patient. You also have to take them through decontamination and sanitization before you hand over to the next to the health worker in the ETU. Yeah, so I have some questions. You talked about the alert should be I know we have a limited time, should be triaged and prioritized. But now you talked about the EMS line, the 912. Now, someone who is in the community might not be knowing the surveillance line. And if they call onto the 912, what does the EMS do? Do the EMS team revert that call back to surveillance team, or you have a way of triaging and assessing these calls, and then you work to respond? Is it okay to talk about that?
Yes, very okay. Thank you for that question. It's a very important question. Yes, because many times EMS receives calls directly.
Yes.
Even this response, we have received many calls. 912 is really short code, and it is easier for the public and the community. So, but the good thing, we are one team, like is the management team, and the pillars work together, and they report to each other, and they do work together. So when the EMS receives calls directly, we plug in, we work with the alert management team, and verification is done at the same time as EMS. So you find that we even have shorter response time to such cases because we communicate to the alert management team, and then verification is done in tandem as EMS also responds to those cases. Yes, so we are the same team.
Okay, thank you so much for that response. Another question is, you talked about the special categories, special cases. Now, if we have a patient is a child and is the one that is positive, and I talked about moving with a caregiver who is not a suspect or is free of Ebola. How would you move such? How do you handle such cases?
Okay, thank you for that. Very good question. So most times the person we're going to move with, who's going to move with this child, children do need care, right? So most times the child is not on their own, and they have already been in contact with this person for the entire period the child has been sick. So despite this person being asymptomatic at that point, they are already a high risk contact. So they will still move. It would most probably be the mother. Yes. So they will still move with this child, and at the treatment unit, they will be guided by the trained teams there on how to continue caring for this vulnerable child, but also monitoring the mother to see if they are going to develop symptoms, and keep them also with the IPC guidelines, keep them able to provide care for them, but also remain safe if they are still not infected.
Okay. Oh, thank you so much, Dr. John. Then one last more question. You talked about, someone was asking on the call, you talked about the ambulance teams going and then assessing the patient, and then for them donning, putting on PPEs. Do you give PPEs to patients also? Do they also don while they are in the patient's cabin as you're putting them in the ambulance? Do you also give them PPEs, or the PPEs are for only the health workers?
No, thank you for that question as well. They're not only for the healthcare workers. So we have these supplies with us, and the teams move with them. Yes, and depending on the risk assessment, it's not prohibited to give a mask, surgical mask, to a patient who's going to be green patient in the patient cabin. And like we have said, PPEs and IPC has really protected us. And it's not, when you protect us, you protect the patient and also the community. So yes, it's a risk by risk, case by case assessment, and it is also okay to, yeah.
Yes, lastly, you talked about the ambulance decontamination after the evacuation. Can you confirm, where is this decontamination done? Do we finish to transport the patient and then ambulance goes back to wherever it came from and then it's decontaminated? Or the ambulance decontamination, where does it take place? In the ETU? Because we are assuming that in the ETU, they're just managing now the cases, all these patients that have been brought. So where is the ambulance decontamination and this team take place? Maybe you can give some more light about that.
Thank you for that. To highlight on that, you do not want to move too much when you are a high-risk vehicle. So we prepare before the response or during the preparation, prepare at the contamination site. And in most cases, it is at the treatment unit or as close as possible to the treatment unit, such that immediately after offloading or reception, of these cases from the ambulance, offloading, there's a designated spot or decontamination point as close as possible to this this place where the patient has been offloaded. Like in the current response, we have it at the ETU. So we have our teams of EMS hygienists that are placed there, and immediately they are already in communication with the communication channels I've talked about, because we alert the treatment unit when we are going there and the time of arrival. So they prepare, ambulance comes in, the receiving team receives, and the ambulance hygienists go in and decontaminate immediately.
Wow.
Yeah.
Oh, thank you so much for clarifying that. I know people have been asking themselves, how does that happen? Now, lastly, this is going to be your last question. I've said last many times, but I can see people bombarding here with questions, and it's okay for us to give them information. What about patients where, like, for example, the suspect is coming from Arua? Does the EMS of Kampala go straight to go and pick the patient all the way? Is there some time when you've had instances where, like, you have to do relays? How do you handle such long distances? Because it can be so, I see it can be so tough to move a patient a long distance.
Yes, so thank you so much for that question. Very, very important. So as EMS, still, we have discussed different scenarios of different transfers. So we're actually developing transfer protocols and SOPs. And yeah, we have been faced with long distance transfers, and we have had to do relay transfers, whereby because of course we have teams across the country, but it is not easy. For example, to be donned all the way from Arua to Kampala, 500, 450 plus kilometers. So we have relay points. We have several referral hospitals in the country, and we do have these structures across the country. So we do communicate and prepare points where a team can meet halfway another team that is coming from a very far, such that one team handles like 200 kilometers, another handles like 250 kilometers, and also other scenarios really. We have come up with certain protocols to handle each of them.
Yeah, thank you so much, Dr. Joel. Thank you so much. Dear viewers, I think you've really taken note of many things. A lot of words of wisdom are being shared. And right now we are going to go into the next item on our agenda, and that's other than talking about safe delivery of clinical care. Now, imagine that you are with this patient. Maybe the patient has a lot of requirements, clinical requirements, and you are the one moving them in the ambulance. What are the things that you should do? How do you move this person? What are the things that you should mind as you, the healthcare worker, with evacuating this person? Remember, the ambulance is a small cabin, as Dr. Joel has told us, and the risk of you getting the infection is high. But how do you make sure that you give care en route, but in the same time preparing yourself? So Andrew is going to take us through a deep dive of how the ambulance look like, and what do the healthcare worker who is managing this patient en route in this ambulance, what do they do, and how do they make sure that they as much as possible prevent infection from them, prevent them contracting and being infected from this patient they are taking. Yeah, so, and after that, we shall have some discussions and questions from our dear viewers, and I'll be updating what next. So Andrew, you're welcome to take us through how do you deliver clinical care, and how do you monitor patient en route to the hospital?
Yeah, thank you so much, moderator, for inviting me in, and thank you, Dr. Joel, for giving an elaborate presentation on how we actually evacuated this case, but also highlighting on how we've done for several cases, not only this one. But also, I should thank you for making my work easy, because most of the things you've mentioned them already, and some that are in my presentation, so I'll not spend a lot of time on those. I'll just quickly dive into And in case I continue repeating what he has said, that means that is a point of emphasis, and emphasis that both of us are confirming that really is very important. So can proceed. So from this case, can proceed. I'm going to focus on about 5 things. One is we need to give care during transportation and how best can we do that, including the monitoring of our patient and while observing the infection prevention and control measures. And then after all, at the end of this all, how do we decontaminate our ambulance? And also, of course, we know documentation is very key during healthcare provision. So just quickly, this is something that I'm sure we are all familiar with. It has been presented here several times. And this is what the government of Uganda, Ministry of Health, is using to coordinate ambulances and also respond to emergencies within the country, the WHO Emergency Care Systems Framework. And again, I will say that we have Ebola, this is just one, but we also have the continuation of emergency care response and services in the country, even during outbreaks. So it's not that whenever there's an outbreak, that is only when EMS comes in. No, outbreaks usually come, and they've always come, and they've found us when we're already in the response. And whether it is during outbreaks or not during outbreaks, we use this. This is a simple framework that we use. What I would just want to say about this is that, and again, Dr. Joel mentioned some of them, we can see from that big red cross, how we largely survive during outbreaks is our triage really is key top notch, and how we process the calls whenever they come in. This is how we are able to sort the patients and be able to know which patient should be evacuated by which ambulance. Again, when you look at that big triage cross, you can see several dispatch units there. You can see different colors, red, blue, what, and so on. So what this means is that even during these responses, we still have to continue giving service. Therefore, just like facilities have isolation units, we also have our ambulances, also units. They also small moving hospital. So we also isolate or designate ambulances that we specifically use during response whenever outbreaks come in. And of course, again, from that very picture, another very important thing at the end of it, I think that is either left, right, where there's that red ambulance and the black spot in the corner down below. Our ambulances that we use, we make sure that decontamination for every referral, for every transfer is key, as we can see from the pointer there. Whatever we do, IPC is a standing or the backbone of everything we do. You can proceed next. Okay, so what are the key areas of focus as we transfer this patient? Of course, as Dr. Joel earlier on discussed, you realize that every evacuation is a process. You cannot skip any process and jump to the conclusion of things. No, usually it has to be a synchronized step-by-step process. For example, Dr. Joel talked about case identification. Of course, even if you call the 912 famous number that we all know, EMS will not just come. We usually get the matching orders from the surveillance pillar. This is one of the pillars in the response. What do? It is their responsibility to pick out from the alert that they receive, as Dr. Joel shared previously, the alert management system. It has the detail of using the case definitions to confirm whether this patient is actually a confirmed case, or this is a probable case, or a contact, or a suspect, and so on. Because again, at the end of the day, whether you're a contact, a suspect, a probable case, or whichever, there are specific areas that you must go. So when EMS is to move, it's very important for the surveillance port to plug us into the call, then you are able to move. And this is how EMS gets activated. And of course, another very important thing is PPE preparation is also very important. After you've activated, your PPE has to get ready. Then during the response, the patient assessment as well is very important. And this can be done in two ways. One, there is a call and dispatch center that do a call assessment to gather the information that will relate to the team that is responding to prepare adequately. But also the team, when it arrives on ground, they also have to do another reassessment, which is very important. Because sometimes we might have delayed, or the patient's condition might have changed, or the information that was actually received was not clear, and therefore the information that the team went with on ground was not the final one. It changed after the team on ground has assessed the patient. And then, of course, another key areas is the transportation, of course, has to be initiated, but this patient, again, has to be clearly handed over with all the necessary information and that the team gathered, but also whatever the team did for the patient en route, this has to be reported to the receiving facility. Then the decontamination documentation are the final aspects of this. Proceed. So, how important is the call and dispatch, and how do EMTs, whenever we're responding, directly interact with the call and dispatch, and how do we ensure that we effectively evacuate these patients? Of course, like I said, the patient will be verified, and the information about the patient, all the details about the patient will be collected by the call and dispatch center, which will be relayed to the ambulance team. So before we respond usually for any evacuation, we ensure as EMTs that our call and dispatch center gives us the right information for us to swing into action. If anyone just calls directly, we've had some of these calls are coming because someone knows Andrew is working in EMS, Dr. Joel is in charge of the ambulance, and then they call direct personal numbers. Even if that comes in, we still link it back to the call and dispatch center for them to give us go ahead. And then the other thing, usually, since the call and dispatch center coordinates between the facilities, this is the referring facility and the receiving facility. We also ensure that at some point, where necessary, that as the receiving team or the evacuating team is plugged into these discussions, so that we can also first understand the dynamics of this evacuation, but also get clearances firsthand and maybe make some suggestions so that we can be able to effectively evacuate these patients. And then the other thing is, again, like Dr. Joel mentioned, and I also emphasize that we have different ambulances, of course, as we know. We have type A, type B, type C ambulances. However, when it comes to these evacuations, we repurpose our ambulances. We shall see some pictures later on how these repurposed ambulances look like. So we repurpose these ambulances, and the call and dispatch center knows which ambulances are repurposed and which ambulances evacuate these patients. So the ambulance is, I could say, taken to seemingly a type A, whereby every other thing is removed from the ambulance and then put aside. Then whenever the evacuation is to be made, after establishing the patient's needs, then we only take into the ambulance what we anticipate we might use, rather than taking everything inside the ambulance that we are not going to use. Then later on, during the disinfection, the process is long. This could almost take over 5 hours, decontaminating each equipment in the ambulance one by one. So which is why we make sure that as the ambulance is going, we take the proper ambulance that's been repurposed specifically for that evacuation. And then we ensure, of course, we are ready by confirming that the PPE that we need, including the supplies, with us. Next. After we brief ourselves, of course, in this briefing, we ensure that we discuss about the patient's condition, we discuss about how we are going to handle amongst us as a response team. Then we sort of like have a plan, including assigning responsibilities of during our evacuation, this is a critical patient, who will do what and who will do what and at what point. So this is something that we do before we move to pick these patients. Of course, while maintaining contact, continuous communication, and being in contact with the call and dispatch, but also the receiving facility, to keep the communication loop intact. And then the other thing, again, that is most important to do is we have to ensure that there is an aspect of a contingence, and this has to be well planned or prepared for in advance. For example, Dr. Joel talked about relays or long distance evacuations. What this means is that whenever a call and dispatch a team is dispatched, there should always be a backup plan, so that in case the team on ground may need urgent support, for example, an equipment has failed and they just need an equipment to continue care and so on, or anything else, there is always a second team on standby to be able to offer this support. And of course, the documentation is key. These are not emphasized further. Proceed. So when all this is done and the team is preparing to move, risk assessment, this is, why do we do risk assessment and how important is it? And what are the key things that we do usually in our risk assessment? Because we all know an evacuation of an Ebola patient is something that puts everyone at risk, and it's really a risky venture because of the nature of the disease. So we have to always assess the risk per evacuation. This is per evacuation. It's not a one-off. And what are the things we consider? One is the patient's condition. Of course, we know first is this patient that we are picking, are they confirmed case positive? Are they maybe a contact? Are they maybe, depending on what information you already have? Because why we need this is going to help us to prepare adequately to know also which interventions or things we are going to be doing while we pick this patient. For example, if this patient is clinically really unstable, this means maybe we'll have to be lifting the patient, we'll have to be getting so close to the patient, doing the monitoring and so on. So we always have to assess the patient's condition. Then we also evaluate as the response team, how ready are we? Are we actually prepared, or are we ready to respond? This covers quite a lot of things. Like I mentioned earlier on, PPE logistically, so all the logistical aspects, fuel, etc. These have to be put in place, including the capacities of the responding team. So, for example, I will give an example. Of course, we know in our response team, we have different levels of the teams that could respond. If there's one team that is already engaged and a call has come in, and the call and dispatch deems this is the team, this call requires a specific team to respond, and that team is still engaged, the call and dispatch center will not just dispatch whoever is around. They'll have to wait and make sure that the appropriate team is dispatched to safely evacuate the patient. Then the other thing, again, as we all know, EMS usually is not a room thing. It is a field, more field. Move on roads, we go pick patients from different locations and so on. So we usually have to have an assessment of the environment in which we are going to work in. And what we look at is the pickup location where we're going to pick up this patient. Where is this patient going to go? What is the access route? The traffic, the weather, etc., the security, And security is very important. We have seen from videos happening in other places whereby there have been attacks to health workers as well and to units. So we also evaluate that as well to ensure that we are safe. Then we also identify any potential hazards and how we could mitigate them. Dr. Joel talked about this already in his presentation, so we'll just proceed. Then the other thing, which is very important, and this is key, as we go to evacuate, we need to ensure that we have an appropriate and proper PPE. Dr. Joel again also mentioned about this. When I say appropriate, because we don't have to, not every PPE is used anywhere. And we've had instances where people want to, even at the driver's cabin, someone wants to fully don in a level 4 PPE. No, that is not what we do. We only use a level 4 PPE when you're going to go to a red zone or a highly risky environment. And in the ambulance, again, as Dr. Joel mentioned, we have 2 compartments. There's the front cabin where the driver sits, that is the green zone. Then we have the back, at the cabin at the back, that is the red zone, sort of like the wall, if I could say, of the ambulance is the back. Then the staff station is the front. Let me use these words. So the PPE have really to be very appropriate, and we know most of this. The gloves, the masks, apron, etc. We can see from the picture, these are very well-dressed people. So this is how we should look like. Key important thing about this PPE is that they should be non-porous. They should be leak-proof, in that whenever there's any spillage or exposure, it cannot get close or get in contact with someone's skin. Then the other thing, again, I would love to say about this is, when you look at this, there is always, it has always been a thought among health workers that we can see this people in red gloves. Those are heavy-duty gloves. It's always common among health workers that the heavy-duty gloves are only used by hygienists. Yes, that is true. But also in EMS, we also use the heavy-duty gloves quite a lot. And when I say heavy-duty, I mean any work that is going to require a tight grip. For example, hygienists, when they're going to clean the floor, they have to hold a tight grip on the brush, etc. Any work that is going to require lifting, for example, the hygienist will require to lift the beams, etc., to move them from one place to another, heavy lifting. In the EMS as well, we also do the heavy lifting. For example, you have a patient who is non-ambulatory and very heavy, and you're going to lift this patient. This is also heavy duty. So for purposes of being a little more safe, we would require that you have an appropriate glove that can be able to hold this heavy duty work. You can proceed. The next.
The next.
Next. Yes, and then the other last 2 things, again, I would mention here is, like I said it earlier on, when we are going to evacuate these patients, we prepare accordingly. So we repurpose. We have patient evacuation kits that we usually move with, and these kits are meant, they are customized to the patient's need. For example, we know that people have phobia for movement in cars. Sometimes these cars, after decontamination, there can be a little bit of smell of jig, or maybe you can move a patient that has just finished eating, and after starting to move, it can trigger other issues like vomiting, etc. Or the patient can be a wet patient that during the movement, the patient can start discharging. So we usually have to prepare a patient evacuation kit that can have a few basic things that you can use for transporting this patient safely. For example, you can carry a vomitor's bag that in case a patient might need to throw up, at least they have a bag that they can use to throw up, maybe a bottle of water if they need to rehydrate, etc. And then the other thing, again, this Dr. Joel mentioned, and you can see from the map here, in Uganda, apparently, we have only one isolation, which is in Mulago Hospital in the central of Uganda. And the Ebola outbreak is the neighboring country, which is the outbreak first was the neighboring country in Congo. And most of the times, we can expect to pick a case from anywhere in the country, and they have to be evacuated to Kampala. So just imagine this patient is going to move from the upper corner of the country there, this is Arua, to Kampala. This is more than 7 hours. So before the team is evacuated, we have to prepare and plan for the distance. This includes the relay system. And again, this Dr. Julius talked about it. The team house cannot be done in the cover for more than 7 hours in the ambulance for purposes of safety of the team that are responding. So we usually have to plan for this kind of evacuations. Of course, this C1 case that we mentioned earlier on, this was an evacuation just within Kampala. But if this case was coming from a far distance, this is something that we're going to consider. Next. This was something that I promised I would talk about, how we clinically give care to these patients. Of course, like I mentioned earlier on, the patient has to be given care en route. And if the patient is critical, then that means the team that is going to give care, the patient has to move at the back of the ambulance so that they're able to adequately give care. And of course, we know our ABCD is emergency care. But key about the care that we do is we follow the clinically established local protocols whenever we are giving care. The other is we also ensure that we manage the symptoms that may present en route, but also at the end of it, we minimize exposure. This is what we try to ensure, that we minimize exposure completely, which is why the patient has to be stabilized before evacuation, so that we minimize a lot of work that can be done during care en route, so that the risk of exposure is minimized. Next. Again, like I said, we have a couple of clinical protocols. You can just skip them through, how we can clean and disinfect the facilities. Move next. In case you need to any injection you need to perform, you need to pass an IV, give fluids and so on. How this can be done, we have clinical protocols. Next, we have a lot of protocols, how we can manage the cleaning of the ambulance. Next, linen can be in the ambulance, how do we manage that? Next, after evacuation of a patient, most times we can have near misses, or we can have situations whereby, just in case the team that evacuated the patient and faced a lot of challenges and maybe got an exposure or close to getting an exposure, we have protocols on how the teams are usually assessed for risk of exposure. This is to ensure that the team is safe, but also they can be supported in case of an exposure earlier. Next. In case someone is exposed, how are they helped? We also have this in place. Next. And then, like I mentioned, and the pictures now has come in. So we can see from this picture when Dr. Joel was telling us that the ambulance is divided into two parts, in front and behind, and there should be a separation. There we are. Again, like we mentioned, we try to ensure that the ambulance, we remove all the unnecessary things in the ambulance. We can see how this is, so that it's easy for that gentleman inside to decontaminate this ambulance. And then if you are to carry, you can see the red bag there, the corner and the oxygen, the very necessary things that you might need for the patient. So, and during the decontamination, of course, any waste that has been generated during the transfer, this has to be removed. Any waste that is generated as the patient gets out, the waste also gets out, and this remains at the unit, the treatment unit. In case the patient has vomited en route or anything, for wet patients, spillage management is very important. That has to be done before the decontamination or the disinfection of the ambulance. Of course, we also know that there are some equipment in the ambulance that can be discarded after the evacuation, and then there are also those that can be reprocessed after the evacuation. So we have to ensure that that is done adequately. Next. This is what I just talked about. The ambulance has to be disinfected. Why? For the safety of the healthcare workers. So for every evacuation, after evacuation, this disinfection has to be done immediately after. And then this has to be performed at the isolation unit by trained staff, the IPC people, who must be donned fully in the level 4 PPE at the facility of the decontamination. And the decontamination of the ambulance should happen at the designated zone where the ambulance disinfection and decontamination happens. Next. Documentation is very important in the patient care form. Dr. Joel talked about this. How do we document after documentation, how do you handle documentation? Those well considered the zoning of the ambulance. The documentation at the red zone at the back of the cabin continues the red zone, continues inside the treatment unit. Those that happen in the front zone, the green zone, these can go to the green zone of the isolation unit. If it ever crosses the red zone, it remains there. It cannot get out of the red zone of the ambulance and cross the green zone of the facility. And of course, again, we not only document the patient information and so on, we also document other issues of the response for purposes of administrative processes and so on, the patient in the ambulance logbook for accountability, mileage, etc., so that we're able to account for some of the issues that have been consumed during the response. And then, of course, if there's any exposure, this has to be documented and report has to be shared with the relevant supervising team members. And of course, all this we do, we always have to follow our checklists. Why? Because the checklist helps us not to skip out anything. We also emphasize documentation of any errors. This is an area that most times, and it can be common, maybe due to fear or I don't know, for some reasons, that if someone has made a mistake, people often fear to document. However, in EVD response, we encourage people to document these mistakes because these are mistakes that can help us for safety and also to know what happens next after the mistake has happened. Next. So this is the last part of my presentation, the key areas really that we need to focus on. The key focus is preparedness, coordination, compliance with the IPC, very important. And also we don't take for granted continuous improvements and appreciation of change in protocols and so on. So whenever there's any change in protocol and procedures, the teams always have to be retrained and information shared with them. And the leadership as well is the backbone of all the things. So the leadership of the team is very important. And of course, these ones can be done through regular drills, by strengthening communication and emphasizing closed loop items considerations and following the quality improvements. Next, when to delay transfer. Next, this Dr. Joel talked about, for example, the patient is unstable, we do not just move because moving unstable patient would mean patient can start deteriorating on the way, and this will call for more work for the EMTs, hence more exposure. So if the patient is unstable, we would prefer not to evacuate immediately, and if they are aggressive. Next. The steps are there. I gave a snapshot of these protocols. They are online of how the ambulances are disinfected and how this can be done. You can just continue flashing them as we see them. They are there. The 4-bucket system is what we use. Continue. Waste management principles. This is something that we also do. The key thing about the waste management is we have high risk and low risk, or let me say red and green zone. How we manage the green, we manage green as green. How we manage the red, we manage red as red. For example, we all know that a bottle of, someone has taken a bottle of water, that one is not an infectious, or how we think that it can go to the black bin and so on. However, in this case, if it's a patient who has handled this bottle, straight to red. Next. How to don and doff. The steps are there, these protocols are there on most websites and WHO websites. We also have all these, how you can fully don. You can just continue flashing them. These are all protocols that are important for us to don. Then we also have a couple of videos that are on YouTube, and also a few of these that we've developed locally here in Uganda that you can go and try to watch some of the things that we do live online. And they can be shared in the chat. I've been informed that they'll be shared in the chat. Thank you.
Wow, thank you so much, Andrew, for taking us through that wonderful presentation. And a word of appreciation to our dear viewers for staying with us from the start till now. Thank you so much. We don't take it lightly. I've seen very many questions that have been asked, and thank you to our panelist who is online, Dr. Mario Nachayuni, and he has been answering most of them. What is still persisting and standing out, I've seen people talking about their CPD's points, and the administration of ECHO EMS session says that they've awarded all the CPD points to the doctors, the paramedics, clinical officers, and they are currently tracking those people, the other clinicians, like people who are laboratories and COs. For nurses and midwives, the team is still working with your council. However, what the council is emphasizing that every time you attend the ECHO session, please note the date and the time in your logbook. So that's like by the time it's cleared out, the link is cleared out, things will be lining to what you put down in the book. Or if you go to renew your license, that should be cleared out. Otherwise, we are so grateful for your time. I can see someone's hand is up. We have a few time left out, 2 minutes left, a few minutes left out, and I'm going to give chance to only 2 people to ask something. I can see someone's hand is up. Is that Tembo? Yes. Gerard, please, can you unmute and air out your view? Tembo, can you unmute? Meanwhile, the
Hello.
Yes, Gerard.
Yes, I'm sorry. Gerard from Bwera General Hospital under the bordering Congo.
Yes.
Thank you, moderator. Thank you, everyone. And I'm in the isolation of Bwera General Hospital. That is under EVD, where we also transport patients of Ebola to regional up to there in Kampala. My question was mostly in emphasizing of transportation. You remember the first child of EVD, the first child that came from Congo passing via Bwera. I was the one transporting, picking from Kagando Hospital to Bwera Hospital. But by then it was still when the EMS was not yet and getting all the session. And we tried to see how the PPE and the disinfection of the ambulance. And unfortunately, we are not having the spraying of the ambulance, spraying the person, and how the ambulance is being sprayed was not as much as necessary, though we have improved, was necessary, not was necessary, that's what I mean. Though we have improved and trying to improve of how we can don and doff the ambulance. But on this, we have a challenge with the issue of, I don't know whether under the WASH, that is IPC, I don't know whether the water ambulance, the unit, the place where the ambulance is supposed to be, where does that water go? Because this patient might be vomiting, might be bleeding, and you find the specific area under the unit, under the treatment unit, where specifically do that water go? Because there is that gray water, black water, and those water. Where does the linkage? Where does that water is supposed to go? Where do we count it? Thank you.
Okay, thank you so much, Tembo, for the question, and thank you for the great work that you're doing in Bwera. We know it's not easy for you to work in this response, to be one of the responders. And I think your question has been noted. It's going to be responded to. But before it's responded to, can we have one more question? And then we'll respond at once. Any more question? Okay, if there is no question, I'll allow Andrew. Please, do you want to respond to what Temba shared?
Yeah, okay, I'll attempt to respond. And since it's one question, maybe Dr. Joel also would love to add something on what I'm going to say. So your worry is, I picked two things out of your question. Number one is, where should the ambulance be decontaminated from? Then two, your worry is the where this water that has, or the flow of water, or the drainage, perhaps, if I would say, where should this water drain? Or yes, so like I mentioned earlier on, during responses, there are designated areas where the ambulances have to be disinfected, including whenever we are performing relays. We have within the country spots that we've designated where the ambulances can do the handover, relay handover, and then disinfect in that area. So whenever you want to disinfect your ambulance, it is important for you to know at the end of your evacuation, where is the designated, and I'll use the word designated in capital letters, place where the ambulance can be disinfected from. So don't take it anywhere. And of course, when the place has been designated, there are structural considerations. For example, one of them is that you just mentioned of drainage. So this water, whenever the ambulance is disinfected, the drainage is an aspect that is considered in the structural establishment of this area. So this water is not left to drain just in the community or anywhere. They are usually soak pits, and this all this is guided to these safe areas. Thank you.
Thank you so much, Andrew, for responding to that. As he has said, yes, the water is not left out. There is a soak pit where the ambulance goes and it's cleaned very well. But all this, as Andrew said, that we have all these protocols and guidelines. If you look at the new IPC guidelines that have been shared out, you will find all this information and you can follow them to either set up cleaning and disinfection for the ambulance point. It's on the website of Ministry of Health. And also, if you get in touch with your hygienist or IPC specialist, your health facility will be able to share out this. And I think they are going to be shared on the Emergency Care Society and other platform where we can access them. Our time has been fast spent. It's exactly 4 p.m. And allow me to take back the microphone to our hosts. Oh, there is a question that has intended to. Mulumba. Mulumba, can you go ahead to share your question? I can see someone was asking how, where they get the vaccines, the Ebola vaccines available. For as you've been, from the previous sessions we had, you been educated that for Ebola Bundibujo, we don't have the vaccine yet. For some other species, we have some vaccines that have been undergoing trials. But for this current one, the Ebola individual, we don't have a vaccine. So that's calls us for the importance of us observing the IPC and be so keen and be vigilant as health workers. Okay, Mulumba, you're trying to say something. Please go ahead. I will just exceed for 2 minutes. Please try to be brief.
Thank you. I'll use 1 minute of the 2, and my question is very simple. How do we engage the communities? Yes, this is for the health workers, but what do we need to do the communities? And my biggest interest was about whether we have a pillar for the community engagement and who is the contact at national, regional, and the other levels, because I deal with the community engagement. Thank you.
Okay, thank you so much, Ms. Amlumba, for that question. I know there've been a lot of sensitization, but Joe, do you want to respond to Ms. Amlumba?
Thank you so much, Mulumba, for that question. Yes, we do have a pillar, risk communication and community engagement, that really plugs in and supports all the other pillars as well. With information, education materials, the IEC materials. They also have activities they plan, and with the district health educators and all those establishments, really, they plug into that pillar, risk communication and community engagement, to sensitize, educate, and really make aware the communities, and support the entire response.
Yeah, in addition to that, there are a lot of guidelines that Ministry of Health has brought out that govern schools, that govern mass gathering, that governs community. So please, let's get those guidelines and read them, so that you don't need to be a health worker or a medic to know this information. This information is important because it's beneficial to you and your friends and your dear families. One more last person, Vincent, I'm giving you 1 minute. I'm stopping on Vincent. Vincent, please, can you unmute? Vincent, are you there? Okay. If Vincent is not there, again, a word of appreciation to our dear viewers for staying with us from the start till now. Thank you so much. We don't take it lightly for sparing some time to come and attend these sessions. And I encourage all of us to take this information back to your colleagues. I would allow the panelists to give us one standing point that you want the viewers to go with from this session. I'll start with my panelists on my left and then on the right. Andrew, you want to say something? One last point, that if they can forget everything, they should not forget that point.
If they can forget everything, they should not forget IPC.
Okay. Great. If you forget everything, don't forget your IPC, because patients are not going to come with labels. But if you've been keen on your IPC, you will not be able to catch the infection. Yes, Joel, which standing point do you want our viewers to go with?
For me, I'll go with communication.
Communication.
We are a team. There are several structures we can get support from. There are several numbers, several materials. So let us all work together, consult where we're not sure, and also educate where we can, to support each other and fight together to break the chain of transmission.
Thank you so much. Thank you so much, our dear panelists. Thank you, Joel, I picked that teamwork. We will not fight Ebola alone. We will not fight as an individual or as health workers alone or as Ministry of Health alone. So that's why it calls community. Everybody has to come on board. If it's your neighbor and you see your neighbor who is unwell and you're not a health worker, please communicate and seek for help, because the numbers are being shared out. We talked about the 912 and the surveillance link. So communication work as a team. So thank you so much for this time. I take back the microphone to our hosts. We encourage you to, at this time, to please switch your video on, your camera, put your cameras on, so that we can have a look at you and take a picture. We can see most of you. Oh, we have the president of the Association of Ambulance in Uganda, APU. Our president, Mr. Chobe, Tom, you're really welcome, and we are excited to have you for this session. Thank you so much. Do you want to say hello to the team? Just an eye. Mr. Tom? Okay.
Mr. Mayor, for those that I think I've seen quite a number of people that saying that they've not been able to get their CPD points. We're still working hand in hand with the Uganda Nursing and Midwifery Council, the Nursing and Midwifery Council of Uganda, and they are yet to activate their portal for CPD. They are hoping to get it done, but we don't know when exactly. And the information that they have is that you should be logging in your CPD points in your books. And we can always verify that with them, just in case they have questions. For the rest of the cadres, their CPDs are up to date. That is for the doctors and then also for the paramedics. We've been able to award the doctors and the clinicians. We are right now tracking the ones for the laboratory technicians as well as the anesthetists, and we shall have their CPDs awarded for all the sessions that we've been able to attend this year. Otherwise, for the nurses and midwives, unfortunately, we are not able to update those electronically. So just keep track of your CPD activities, and you can always claim them at the end of the year. Thank you.
Yeah, thank you so much. I can see a lot of people. We are so grateful for joining onto this call from the start at 2 p.m. till now.